Hello and welcome. Lighthouse Healthcare Advisor presents to you today 2021 E&M changes. Let's review the agenda for this webinar. We will see the disclaimer for this webinar. Quick overview for E&M coding prior to 2021. 2021 E&M changes. Prolonged service. Medical decision-making changes. E&M 2021 summary chart, revenue table and 3 key steps to remember for accurate documentation. At the end of today's session you will understand on new 2021 changes and guidelines. A few disclaimers. So attendees should already have a basic understanding of E&M coding prior to this lecture. The overall intent of this presentation is to provide attendees with thorough understanding of the available 2021 E&M changes according to AMA guidelines. So if you have further question about this presentation, please contact Lighthouse Healthcare Advisor. We appreciate your feedback. Alright. Now let's see what are the 2021 changes for E&M. Let's get started. Before we see the 2021 changes, let's take a quick glance at E&M prior 2021. Prior to January 1st, the 3 key components to decide on an E&M level. They are history, examination and medical decision making. A good medical record will have all these 6 elements. They are chief complaint, HPI, RAS, PFSH, examination, MDM. The first key element is history. History has 3 components. History of present illness, which is called as HPI, review of systems, which is written as RAS, then FISH. Past history, family history, social history. Level history is classified as problem-focused, expanded problem-focused, detailed and comprehensive. Second key component is examination. The examination is performed by the physician. There are the 15 systems under examination. Based on the number of system reviewed, level of examination is decided by the coder. Examination is classified into 1995 and 1997 guidelines. Examination has 4 levels: problem-focused, expanded problem-focused, detailed and comprehensive based on how many systems were examined during the visit. The third key element to decide on an EM is medical decision making, which is called as MDM. MDM is further classified into 3 little tables. The first table is the number of diagnosis or treatment options. This table represents the disease status and workup plan for respective documented diseases during the visit. Each is denoted by points. The second table is the amount or complexity of data reviewed. This is where the points are counted based on clinical tests ordered, test reviewed or test result discussed with the performing doctor during the visit. The third table is the table of risk. There are 3 columns under risk table. First column is for type of conditions or diseases that patient have. Second column is what are the procedures ordered to diagnose or treat the respective diseases, and the last column describes what are the management options done to care for the disease. Based on these tables, MDM can be classified as straightforward, low complexity, moderate complexity or a high complexity. How to decide on a final code based on 3 key elements. Let's assume we are leveling for a new patient visit. E&M guidelines says that for a new patient 3 out of 3 key elements should meet to get to a code. Otherwise pick the lower level code. For established patient 2 out of 3 key elements should meet to arrive at a code. In this scenario, for a new patient, if history is EPF and exam is detail and MDM is low, what will be the new patient E&M code? For new patient 3 out of 3 key elements should meet, else the lowest key component drives the code. Okay. So the code here is 99202. This is a picture of CPT new patient E&M codes. Alright. Now let's see what is new for 2021. Why and what are the major E&M changes for 2021? Let me first answer why the changes were made. The E&M guidelines changes were made in 2021 because of the outdated guidelines. Make it easy to teach, Focus on MDM and time, meaningful documentation, value-based care. The major changes in 2021 summary changes are listed on the slide. Prior 2021 there were 5 levels of new patients which are 99201 to 99205. Effective 2021 there are only 4 levels of new patient which is from 99202 to 99205. Yes. You heard it right. The 99201 code is deleted in 2021. Established patient codes will remain same which is 99211 to 99215. Next major changes are the history and examination will not be a key component to decide on E&M level. Effective 2021 MDM or the time will determine the level of office visit or E&M. As discussed in our previous slide, I have listed out the effective and deleted codes in detail for an office visit. As explained earlier, code 99201 is deleted for 2021. MDM or time is the key factor to decide an office visit level. History and examination are not calculated to decide on an office visit level. But AMA still suggests providing the history and examination documented for the visit. New and established patient documentation remains the same for 2021. So a new patient, a patient who has not received professional services from a physician in the same specialty, in the same practice for 3 years. As I mentioned, time or MDM is a deciding factor for an E&M level. So let's see what is the guidelines for time-based reporting for an office visit. Total time for 2021 E&M includes preparing to see the patient, which can include review of tests, prior medical visits, obtaining and or reviewing separately obtained history, performing the medically appropriate exam and or evaluation, interpreting results and or communicating results to the patient or family or caregiver, ordering medications, tests, procedures. The table on the right denotes the difference in reporting the time prior 2021 and effective 2021. For example, the first table is for new patient E&M. 99201 is reported as 10 minutes face-to-face time prior 2021. Whereas effective 2021 the 99201 is a deleted code. Next 99202, prior 2021 the total time reported should be 20 minutes to code 99202. Whereas effective 2021 the CPT 99202 can be coded if the total time is 15 minutes to 29 minutes. Other time-based codes are listed below. Table 4, represent the total time for established patients. This table provides you with prior to 2021 and effective January 1, 2021 time-based established patient codes. Alright. The main difference in time-based reporting prior to 2021 and effective 2021 is face-to-face and non-face-to-face time with the patient and with the family of the patient. Prior to 2021 percentage of the encounter should be spent face-to-face activity on the date of service, whereas effective 2021 the total time is calculated face-to-face and non-face-to-face activities on the same date of service. The next important component for office visit level selection is MDM for 2021. The level can either be selected using time or MDM documentation. Let's see how MDM affects selecting an E&M level. In 2021, the MDM table has extensive edits in code selection. There is a new term, independent historian, is added in the second table of MDM, which is the data review table. There are 3 categories added into data reviewed MDM. Here is a quick glance at the changes prior to 2021 and effective 2021. If you look into this table too, prior 2021 the diagnosis table says the number of diagnosis and management options. But effective 2021 the diagnosis table reads as the number and complexity of problems addressed at the encounter. This means each condition listed during the visit should be addressed. Addressed means each diagnosis should be supported with the management of care on the same date of service. For example, if the physician documents in the assessment as diabetes mellitus, diabetes should be supported by the management of care. I mean, doctor documents metformin medication is reviewed, or diabetes is stable or unstable, or lab test reviewed, etc., can be considered as the support. Thus, disease with the management of care documentation adds a point to contribute to deciding an E&M level. Next is the amount of complex data reviewed was acceptable prior to 2021. Effective 2021 amount of data reviewed, and this data should be analyzed and documented result of the analyzed data. Finally, the risk table for 2021 needs the management of care documented for each disease that patient had during the respective encounter. This is the MDM table for 2021 and plays a vital role in deciding E&M code. Please take a print out of this table. This is the only table which decides on visit level for 2021. This is one-stop table. The table is used for MDM-based reporting. First two column has codes and range of time to be reported for respective office visit level. Now please look into the MDM table. The first column number and complexity of problem addressed remains same except for mild exacerbation is removed. Second column of data reviewed and analyzed, you will find category 1, 2 and 3 added to the MDM table. If 99204 or 99214 is to be reported for a visit, then one of the category of amount of complexity of data reviewed and analyzed should be met. To report 99205 and 99215, 2 out of 3 categories should be met. Category 1 is for review or order test or assessment requiring an independent historian. Category 2 is interpreting the test result performed by other doctor. Category 3 is for discussing the management of the disease or test results with external doctor. Last column, the risk table, shows the management options. Once the MDM table is understood, the next is to know how to code for prolonged service. Prolonged service code is changed for 2021. Commercial insurance use add-on code 99417 as prolonged service, whereas Medicare code for prolonged code is G2212. Alright. This slide shows detailed coding guidelines for prolonged services. The table is classified as new patient prolonged service coding towards left and right hand side has established patient prolonged service codes. Let's take an example. For new patient 99205, total time reported is 60 to 74 minutes. If physician spends total time for the visit anything between 75 to 89 minutes, then this visit is coded as E&M code 99205 and a prolonged service code as 99417. Now if the new patient visit is for 100 minutes, how do you code for this visit? It is simple. This visit should be coded as 99205 and 99417 times 2. This visit can be face-to-face and a non-face-to-face on the same date of service. The documentation should be clearly state the total time to code for E&M level and a prolonged service code if satisfies. Are you all ready? I have a scenario for you. But before we see the scenario, these are the steps to assign an E&M code. So the first thing you want to do is to inventory. Inventory any diagnosis that we see in the medical record. Okay. Second, inventory any procedure or services. Next, we determine presenting problems, data complexity, and risk using the charts. Finally, we are going to level the code or select the code. Alright. You ready? Here we go. Here is the scenario. A 60-year-old woman arrives to see Dr. Lung, a pulmonologist, for an initial visit. The patient has a constant cough due to smoking and some shortness of breath. No night sweats, weight loss, night fever, chest pain, headache, or dizziness. She has tried patches and nicotine gum which has not helped. The patient has been smoking for 40 years and smokes 2 packs per day. She has a family history of emphysema. An extensive 3-system exam was performed. Dr. Lung discussed in detail the pros and cons of medications used to quit smoking. Prescriptions for Chantix and tetracycline were given. Provider reads the patient's record including scans ordered by the patient's primary care. A chest X-ray was carried out, the physician read the result, then ordered a cardiac workup because he suspects heart disease. The physician diagnosed the patient with COPD. The patient was advised to quit smoking and follow up in 1 month. Select the appropriate CPT code for this visit. Just a reminder, we coding for the encounter for 2021. Let's see. Now I am going to quickly walk through this scenario using the medical decision-making table. Here is our step. First, we are going to inventory the diagnosis or signs and symptoms. According to the documentation, the diagnosis is patient had a cough and some shortness of breath. Family history has emphysema and the diagnosis is COPD. Let me list down all the diagnoses. Next, I am going to do inventory the procedures and services. There are some services here. We have an extensive 3-system exam that was performed. The doctor discussed the pros and cons of medication used to quit smoking. There is a prescription. Read patient's record that was ordered from other PCP of the patient. Scans were ordered. A chest X-ray was performed. The physician read the result. The doctor ordered a cardiac workup. There are several things performed here. So I am listing the inventory here. It is easy for us to see when we audit. Now next thing we want to do is to determine the problem or data complexity and risk from the chart. So that is what we are going to do next. Everybody with me? Now let's move on to the next slide. So number of the complexity of the problem addressed. Well, this will fall under moderate because there is one chronic illness that is COPD with exacerbation because this patient has a constant cough, shortness of breath. So the number of problems is moderate. Now next thing is to see amount and or complexity of data to be reviewed and analyzed. Alright. So this one. We are going to extract the information from under procedures and service inventory. Okay. The 4, 5 and 6 because this is what doctor is doing for the patient. I would say this meets the requirement of moderate for data complexity. If you look under category 1 for moderate. 3 there are 4 bullet under category 1. So at least 3 out of 4 should be met for consider it as moderate. So let's go and take a peek. First one, prior external note has been met because if you see the record it says doctor read the record and scans are ordered by the patient's PCP. Okay. Now we have review of result of each unique test. Did that happen? Yes. Physician read the result of that X-ray. Next, ordering of each unique test. Is that take place? Yes, it is. It says physician ordered the cardiac workup. Okay. Now we have filled 3 out of 4 there. That's what we need in order to code category 1 moderate amount of complexity. So now our data complexity is going to be moderate. And now, we are going to move on to our final, which is going to be the risk. Alright. What do you think the risk is going to be here? Well, if you look under procedures and service inventory, it looks like there was a prescription written. If you see under moderate risk, you will find prescription drug management falls under that. So we can use prescription to figure out the risk level. So that would fall under moderate. Okay. Looks like we have a moderate risk level. Now we have completed all of those. Now our final step is going to be to select the code for the level. Alright. Let's go to our charts here. And we are going to plug in all our information. So remember we had a moderate number of complexity of problems with COPD exacerbation. We also determined there was data complexity fell under moderate. Those 3 elements were met. There was prescription drug management, so the level of risk is moderate. This is easy because they all fall within one row. So we need to see based on documentation if it is a new or established patient. That is easy because it is an initial visit, so it is a new patient. Hence the code would be 99204. Now, what if you have the elements in different rows? How do you arrive to an E and M level if elements are in different rows? Let's say your problem is low complexity. Data complexity is moderate and the risk is high complexity. What do we do here? Which code do you think we are going to take here? In this case, very simply, we will take out the lowest level and take out the highest level. Consider the middle one. And that's it. This is how you arrive at a code. I hope, now you have a better understanding of getting a level using the medical decision-making tool. This tool should be effectively used from the date of services in January 2021. This slide is an overall comparison between prior 2021 and effective January 1, 2021 E and M changes for new patients. The last column highlighted in yellow has a working RVU for each office visit level. This slide is an overall comparison between prior 2021 and effective January 1 of 2021 E and M changes for established patients. The last column highlighted in yellow has a working RVU for each office visit level. This slide showcases prior 2021 and effective January 2021 working RVUs. This is one of the important slides for today's presentation. I cannot emphasize enough about the importance of good documentation. We are moving towards quality-based care and documentation is of utmost importance always and especially in 2021. I would like to share a quick tip for good documentation. First, document the highest specificity. Please avoid documenting unspecified codes, instead report higher specificity code. Always follow MEET criteria. MEET stands for monitor, evaluate, assess, and treat. Describe in a simpler term, report and document management of care for all the disease for the respective date of service. Finally, and the most important step is to submit all the documented condition on the claims. The claim has 12 opportunities to submit the diagnosis code, which is from 21A through 21L of the claim form. Please include all the chronic conditions that the patient has and reviewed during the visit along with the reason for the visit diagnosis code. Thank you for watching the video. Our contact information is on this slide. Have a wonderful week. Stay connected.